Louise.
Yeah, hello everybody. So I'm Louise Merriman and I'm the GP Cancer Lead for Joined Up Care Derbyshire. And thank you very much for inviting me to come along and talk about cancer services, the current state, what's happened during the pandemic and where we are at the moment. So thanks very much. Thanks to Chloe, who I don't know, but Chloe, I understand, is going to move my slides on, and I hope I don't sound too dictatorial when I say next slide, please. But that's really helpful. So if we go to slide 1, I'm going to turn my video off just to help my internet cope. So this first slide is really just to illustrate the reduction we saw in referrals of people with possible cancer. If you look at the mountain range at the back in grey, that shows pre-pandemic levels. There's always variability through the year. It's interesting, not many people are ill at Christmas, but they present in the new year, so figures tend to go up in January, for example. So they're the fluctuations that we would expect to see on average. And then if you look at the green columns, that shows the effect of the pandemic. So we all locked down in March 2020, and we saw a reduction in all referrals, and this is the effect on referrals for people with potential cancer diagnosis. But if you look at the red columns, they show how well we've recovered as we've come out of the pandemic, to the point that in some tumour sites we're above the expected time of year. Chloe,
I think we may be having some connection problems now. I'm not sure if that's just me, if Louise has just dropped off there.
Can you hear me?
There we go. Yes, I can hear you now.
Yeah, we can hear you, Doc.
So slide 2, this just shows the 5 highest tumour sites which we see the most activity in. We always see the most activity in. This is skin, breast, colorectal, urology and upper GI, so upper gastrointestinal problems. And you can see the same trend across all of these 5 tumour sites, that we saw this devastating fall in referrals at the beginning of the pandemic, but really quite a pleasing recovery quite quickly as we went through the rest of 2020 to find ourselves in a good position now. Next slide, please, Chloe. So GP practices had to change pretty quickly. We had all this news coming in about this pandemic that was possibly coming, and the next thing, everything seemed to shut down overnight, and practices had to think on their feet. And it may have felt to some people like their practices suddenly closed. And I think, it's fair to say that practices did go down to a very, very, very reduced service for at least a few days, while they thought about how they would safely bring patients down to the practice without potentially exposing them to COVID on top of whatever else they might be presenting with. And initially, most consultations were done by telephone wherever possible. Increasingly, as we got our practices up and running with one-way systems and glass screens and sort of controlled door entries, we were bringing people down face-to-face, particularly anyone we felt needed to be seen and assessed clinically. And then we were very lucky that software companies very quickly came in and supported us to have video consultations and internet consultations. And that was great because the telephones became a huge pressure point. And, I'm sure many of you have experienced long waiting times, waiting to talk to somebody at your practice. Practices did try and get as many lines in as possible, and as I say, try to look at other ways of getting patients to be able to communicate with them. But still, it is an ongoing problem, and obviously there are certain times of the week when there is a pressure point. And practices were also put under huge pressure to help deliver the vaccination programme. And the papers and the politicians were full of the fact that non-urgent work needed to be stood down. I think most practices tried to continue that work as much as possible, but certainly I think it's fair to say that it was deprioritized compared with the vaccination program and anybody who was presenting with sort of emergency type symptoms. Can we have the next slide, please, Chloe? So in theory, anyone needing advice because they were concerned about possible cancer symptoms could speak to their GP. But as I say, you know, there was some frustration caused by long wait times on telephones. Hospitals also made an effort to quickly put in measures to ensure that patients having to go to hospital were safe. There were a lot of procedures that they had to put in place in terms of cleaning. And there was a huge pressure on beds because sick patients were taking up beds which were otherwise going to be used for people going in for perhaps cancer surgery or cancer treatments. And this is particularly a problem when we've got people with COVID needing ventilation on ITU. So they would be blocking ITU beds. So any surgery that might need patients to go to ITU or a high dependency unit for a few days after surgery, their surgery was being postponed. The workforce worked incredibly hard through this time to try and continue keeping cancer pathways running with minimal delays. But I think, you know, inevitably, some people did have delay in their pathways. Can we have the next slide, please, Chloe? So the message was, if you had worries about your health, you were to contact your GP practice straight away. But my concern as a GP was that these messages were drowned out by the public health and politicians' messages of stay at home and the NHS is extremely busy. And also, I think particularly in the older generation, you know, we're known to, you know, as a group of people who do what we're told. And so when we're told to stay at home, that's precisely what we do. And so there was some very mixed messaging going on. And I think people in need thought they didn't want to waste a GP's time. And it's amazing, even now, when I'm phoning patients on a daily basis, they're apologising for disturbing me when we're busy and, you know, sorry if I'm wasting your time, doctor. And I think, you know, we have to be very careful and we have to learn from this going forward, that, you know, if this is ever going to happen again, and people say we will face further pandemics in the future, that we have to make sure that the messaging is right, because I think we lost a lot of ground at the beginning because of mixed messaging. But increasingly, we've tried to change that messaging, and there's been a lot of national campaigns, including Help Us to Help You, as well as work done by Macmillan, to ensure that people understand that it is important, if they've got health concerns, that they don't leave it, because many things, whether it's cancer or not, the earlier you present with it, the better the prognosis in general. Can we have the next slide, please, Chloe? Other things that helped people access help, I mean, not in Derbyshire, but certainly nationally, people were looking at having hotlines so that they could take the pressure off of GP telephone lines. There's been a lot of work done creating apps. You know, a lot of people, even elderly people, have smartphones these days, and they're extremely proficient at using the internet and using apps. And so this helped people to access information, really to sort of almost reassure them and give them permission, if you like, that it was okay. They did have a significant symptom that meant they should contact their GP. And I think that has proved helpful. And the patient support app via the Health Zone for both Derby hospitals and Chesterfield Royal has proven very helpful in terms of supporting our known cancer patients. in terms of what to expect in terms of diagnostics and treatment and support. And Macmillan has a very accessible website which has a great section on concerning symptoms. So it was another source that people could go to sort of almost double check whether they were right to worry about something. Can we have the next slide, please, Chloe? So this slide really just reiterates the waiting times for cancer that we all try and work to. I mean, trusts are held to these waiting times, and financially, it's in their interest to make sure that they keep up with them. For years, we've worked with what we call the 2-week wait rule, which means that if you're referred from your GP with worrying symptoms to the hospital, you should be seen within 2 weeks. In fact, that's going to go, because I think they have felt with the way that diagnostic pathways have changed, that's not necessarily the best waiting time to state. But at the moment, we're stuck with it. But it will go probably sometime this year. But the new introduction of the faster diagnosis standard, which suggests that everyone who's referred to the hospital with worrying symptoms should know one way or the other whether they've got cancer or not within 28 days of that referral, I think is an excellent target to work to. Because my experience when I refer patients is that, you know, patients, they find that waiting time very, very difficult. Actually, if they're given a diagnosis of cancer and then a plan about what's going to happen in terms of treatment, they then cope much better. But that interval between being referred and not knowing whether or not they've got cancer is an extremely difficult time. And so to see that come down to 28 days maximum from a GP perspective, I think is excellent. And I'm sure all of you on the call will agree that from a patient perspective, that makes sense. And then there's these 31-day, 62-day rules, which, you know, just in brief, effectively, from the time you're referred, you shouldn't wait more than 62 days to start any definitive treatment. 62 days sounds like a long time, and in most cancer sites, you'll wait a lot less than that. But obviously, some cancers are extremely complex. You need to make sure that you know exactly the stage of that cancer, the cell type of that cancer, to make sure that you come up with the best possible treatment pathway for those people. So it's better sometimes to take that little bit longer to get the treatment right from the beginning. Could we go to the next slide, please, Chloe? So there's been lots of initiatives that we've come up with to try and facilitate delivering these cancer targets for people. And particularly at the moment, where in some tumour sites we're actually seeing above the expected level of referral numbers, it's been important to try and address the demand capacity equation to make sure that we're not just building up huge waiting lists for people. And one of the very good initiatives that's come along is the breast pain pathway. Now, I've been a GP a long time, and I remember when I trained, breast pain was still seen as a worrying symptom that we should refer people urgently to hospital to exclude cancer. But over the years, many research trials have been done to look at the place of breast pain with respect to breast cancer. And it's now well understood that if someone has breast pain alone, whatever the nature of that breast pain, it is not related to breast cancer. And so what we don't want to do is be referring these people to a breast cancer clinic when there is no need to do that. And that's for two reasons. One, it's not good for a lady who's got breast pain to be given the impression they may have breast cancer. That causes a huge amount of psychological morbidity to them, and they feel understandably very anxious. And secondly, if all of those women, and breast pain is extremely common, if they end up in a cancer clinic, then they're going to cause problems in terms of capacity in those breast cancer clinics. So it's going to lead to delay of the women who do end up having breast cancer receiving their diagnosis. So this has been an initiative that we've had running now for nearly a year in Derbyshire, and it's proven both popular with patients and extremely successful in trying to reduce the numbers going through the potential cancer clinic for breast. We also know, and we've known for a few years now that many patients present with cancer with very non-specific symptoms. That might consist of some unexplained weight loss or some persistent undiagnosed abdominal pain. And historically, we know that these people have been sort of pushed from pillar to post. They don't fit for a specific tumour site. They might be referred to colorectal, who don't find a cancer but don't look wider than that, and then they end up under a different tumour site, and so on and so forth. And they end up being stuck in the system and end up with a very untimely, not very good experience of the diagnostic pathway. And so we've now introduced a non-site specific pathway, which is primary care led. And this has led to these people receiving their diagnostic tests and their diagnosis in a much more timely manner. And the patient experience has improved hugely. So that's been fantastic. This started pre-COVID, but during COVID has proven very useful as well. And then the lung pathway, we used to traditionally send people for a chest X-ray, and then if there were concerns about the chest X-ray, we'd then have to do a further referral into a CT scan. So these were all introducing delays. The patient may be seen in a chest clinic appointment without the result of their CT scan, and then that clinic appointment is less helpful. And now we have this lovely pathway where patients are advised they'll go for a chest X-ray, they'll be seen urgently for that chest X-ray, reported urgently, and within 3 days, if there's worries on the chest X-ray, they'll then have a CT scan. By the time they're seen in a chest clinic, the result of the CT scan is available, and so it leads to much more timely diagnosis of lung cancer. Can we have the next slide, please, Chloe? And really, this has been the direction of travel over the last 5 years, that GPs increasingly are getting better access and more timely access to diagnostic tests without a patient having to be referred to the hospital first. And during COVID, obviously, there has been a push to increase this even further. Now, for those of you on the call who are of an age where you're doing bowel screening, you'll know, if you've received a kit, that we no longer have the fecal occult blood test. We have a test called fecal immunochemical testing, which is far more sensitive and specific for picking up colorectal cancer. It's also a much friendlier test to do. You just have to do it on one bowel motion. You don't have to keep it in your fridge while you get 3 consecutive motions. We use this now in general practice, and it's measured at a higher sensitivity than for the screening test. And this helps GPs to distinguish between people who've got significant bowel symptoms and those who, it's less sinister. So this test is done in general practice upfront before any discussions about a referral onto colorectal clinic, and depending on the level of that test result, which we provide to the specialists, if it does end up in a referral, they can then decide the next best test. So dependent then on the patient's physical state and on the level of the fit test, they can then be put into either a list for a CT scan, a CT colonography, or for colonoscopy. And so you can see that this is all helping to triage people into appropriate testing and reduce potential waiting times on just one test. GPs have also had improved access to advice and guidance from our specialist colleagues. And again, that helps us to decide upfront before a referral whether a referral is indicated, how urgently that referral might need to be made, or whether we could, in fact, do some more testing within primary care before any referral is necessary. When we refer people to hospital now, instead of them just being referred straight to an outpatient appointment, the hospitals will receive the referrals, and in most pathways, specialist nurses or clinicians, special secondary care specialists will look at those referrals and triage the next best management, which might be another test, or it might be a clinic appointment. And again, it just helps to reduce those bottlenecks within the system. It is interesting, though, that some patients still choose not to attend appointments for a variety of reasons. Now, pre-COVID, our problem was that people would perhaps prioritise a pre-booked holiday, but during COVID, I think it's been more anxiety around COVID. Actually, if you look at the reasons for breaches on those cancer waiting times, often the reason is because patients do not attend their appointments, which is often, both frustrating and disappointing. And, the important thing is patients need to understand that if they've been referred, there is an importance for them to go and have that test and, then receive a diagnosis or not, and have their treatment planned. Can we have the next slide, please, Chloe? So briefly, we all, I'm sure, feel that we all know about COVID vaccination now. I'm sure we've all had plenty of vaccinations into our arms. And for the 75 plus age group and those who are known to be immunocompromised, so have lower immunity, we're now delivering the 4th dose. Now, this is particularly important for cancer patients because obviously cancer patients on chemotherapy do have reduced immunity. And so they were encouraged to, from a very early stage, get their boosters, get their vaccinations and their boosters, and they will sit amongst the group of people who will very quickly get their 4th dose. It's important to say that cancer is always prioritised in the NHS. It always appears in the NHS plan as a priority, but hospitals have done their best to prioritise cancer diagnosis and treatment throughout the pandemic. And where patients have had to wait longer, perhaps for their surgery, they've introduced preoperative chemotherapy for some of those patients where it's felt to be an advantage. And radiotherapy traditionally is a lot of visits to hospitals to have your fraction of radiotherapy. So it might be Monday to Friday for 6 weeks that you're going to Weston Park to receive radiotherapy doses. But after some research and some rejigging, a lot of the tumours we found respond just as well to higher fractions, which patients tolerate very well, but less of them. So less visits to the hospital, which puts them at less risk of COVID. And also patients get very tired with those constant regular trips to the hospital. And so I think it's been well received by the patients who've experienced less trips for the radiotherapy. And as I've already mentioned, straight test pathways are excellent. You don't want to be hanging around in the pathway, just going for a bit of a chat with a consultant. It might all seem very friendly and very nice, but actually what you need is your diagnostic test as quickly as possible. And so any straight test pathways have been welcomed, and a lot of those have either been developed or are being developed as we speak. Next slide, please, Chloe. So despite all of the problems that I've tried to outline, pre-COVID, the NHS plan set out 2 bold ambitions for improving cancer outcomes. It stated that by 2028, the proportion of cancers diagnosed at stage 1 and 2, so at earlier stages, would rise to 75%. And from 2028, that would mean that 55,000 more people each year would survive their cancer for at least 5 years after diagnosis. So essentially, this is saying diagnose cancer earlier and people will do better. They'll have more treatment options and they'll generally respond better to their treatment. And if you were to look at the current numbers as a totality, and it does vary between tumour sites, currently, around 50%, slightly under 50% of patients receive a stage 1, stage 2 diagnosis. Most of them present, or certainly the other half present at stage 3 and stage 4, and therefore have a poorer prognosis. So it is really important that all of these innovations we put into place concentrate on not just a faster diagnosis for people, but an earlier stage diagnosis to see more people survive their cancer. Can we have the next slide, please, Chloe? So the pandemic's been awful for so many reasons, but equally, oh my goodness, it galvanized change within the NHS. As someone who's been a clinical lead for not too short of 20 years, I've spent a lot of time talking to colleagues about change, and people, both professionals and patients, don't like change. It's quite a difficult thing to bring in. And part of that is that when we're busy doing the day job, it's difficult to get the headspace to think about, well, how could we do it better? But what the pandemic did was made us very quickly look at what we were doing, question what we were doing, and say, is there a better way of doing it? I have to say, it's been incredibly impressive to see all of my colleagues just very much challenging themselves to do better. And we've learned so many lessons. And I think we've extended the way we communicate with patients. We've realised how important it is to communicate with patients. We generally were pulling people up to the hospital far too many times to follow them up when there wasn't evidence to suggest that was helpful. And we've definitely decreased unnecessary follow-up. We've decreased unnecessary pre-test appointments. And by triaging people, we're definitely reducing inappropriate referrals into hospitals, and we're making sure that people are seeing the right people at the right time for the right tests, all of which is really good news. Can we have the next slide, please, Chloe? So the non-site specific pathway, there might be some questions on that, I don't know. It's something that is a very exciting new pathway, which I think we'll see more and more of. I think it's excellent that as a GP myself, to have access to timely diagnostics is great, because, I don't want to be referring people to hospital if they don't need to go. It's much better if we can keep care closer to home, as long as we can maintain the quality. Telephone and video consultations have meant that people can access the clinicians, and particularly at a time when patients were going perhaps to receive bad news and weren't allowed to take family members with them, patients often chose to have that delivered over a video consultation where they could be in their own living room with their family around them. And we've learned a lot of lessons. And I think going forward, we need to understand that patients might want that choice. It might be quite difficult in terms of transportation links. It might be quite difficult in terms of people having all the family members they want in an outpatient setting. And certainly in general practice, we've seen the way we've been able to bring our more housebound, immobile patients to us without having to physically bring them in, or without us physically having to go out to them, which of course takes a lot of time out of our day to get in our cars and go and find these people. And the engagement with our clinical teams has been great, because if we want to have meetings to improve pathways with our secondary care colleagues, that takes them away from their outpatient setting or their surgery. So to be able to have the technology to have meetings like this means that we've had great clinical engagement. And I think going forward, although I think we will want to have some face-to-face meetings, we'll see us continuing with a lot of internet meetings for the convenience and to reduce that wasted travel time. Can we have the next slide, please, Chloe? Oh, that's me done. So I hope that that's brought you up to date with where we are with cancer during this difficult time and going forward. And I'm more than happy to take questions. And Monica McAlinden, who's the head of cancer commissioning for the Joined Up Care Derbyshire system, is also on the call. So if you ask me anything tricky that's more commissioning based, I'm sure Monica will be more than happy to field those questions.
Okay, brilliant. Thank you very much, Louise. Very informative presentation, and we got through a lot there. I'm going to jump straight through to Richard, who has his hand up. If you want to come in, Richard.
Right. There's an issue about whether you should see a GP or hold a video conference. It appears that we we're not formally asked. Given that I've just had a letter about one of my annual tests, to find that it's going to be a telephone call. I don't recall ever being asked whether I want to do it that way. And there seems to be a lack of consent about this. I think there should be some formalisation of this process, because some people want to do it because it's a very sensitive issue, such as cancer, such as the concern about cancer, and some people will not want their family to know they're talking to anybody about it. But we don't appear to have given an option to people. In the same way, if I have a needle stuck in my arm or a piece of scalp taken off my brain, I have to sign a form to say I'm going to do it. I just think that we're not asking people formally. We're making a lot of assumptions about the convenience of video conferencing.
Yes. So Richard, let me try and answer that question. And I think it's a complex question. It's a very good question. And I think wherever possible, we absolutely want to ask patients what suits them. But I think, unfortunately, we are also working within a system with huge constraints. And sometimes the patient isn't best placed to make that decision. Now, that sounds very pompous and isn't meant to sound like that. But I have many patients who would like to come and have a chat with me most days of the week. And if we lived in an ideal environment where I had lots and lots of time every week when I could do that, then that would be lovely. But it's not practical. So we have massive workforce issues in the NHS that we had prior to any COVID pandemic. But COVID, unfortunately, has seen even more pressures on the workforce. Because of the pressures, a lot of people have chosen to leave. And we also knew we were building up workforce issues anyway. So sometimes we have to allow the clinician to make a decision about what is most appropriate. Now, I would like to think that I talk for my GP colleagues, but that's a difficult thing to do because there's lots of different opinions out there. But, you know, if someone clinically needs to be seen to make a proper assessment, I would like to think that that GP would bring them in to see them face to face. But there are many things that can be dealt with on a non-face-to-face basis. And although I hear what you're saying, that some of those things the patient may prefer to be seen in person, it isn't always essential. Now, if it's a sensitive thing, or certainly if any kind of examination needs to be done or procedure, it has to be face to face. So that will continue. And in hospitals, I mentioned about delivering bad news. I think there is a plan to try and offer people a choice. And some of my site-specific tumour colleagues at hospitals have already caught on to that, and others are a bit slower to do so. But I think what I'm basically saying to you is, absolutely, in principle, patients should be asked, patients should have a choice, but life, unfortunately, is complex and it can't always be that straightforward. So I haven't got a black and white answer for you. I think you have to trust us with you as patients to make the best decisions about any individual circumstance, about whether face-to-face is the best way forward or whether it can be dealt with in a different way.
Okay, thank you very much, Louise. I'm going to move on through the hands that I can see raised, and apologies if I've got the order wrong, but I think it was Stella next. If you want to come in, Stella.
Hi, morning. Morning. It's just a question. I live in New Mills in the High Peak, so I have a cancer concern. I'm post-transplant, and my transplant unit isn't in Derbyshire. It's another trust, which is in Manchester. If I get referred, I have to go to another trust Now, the situation that seems to be happening with Derbyshire is there's a very mixed message, because I'm being told one thing by my transplant unit and I'm being told another thing by Derbyshire. So between the two of them, it's taken me 8 months to get the referral that I should have had 9 months ago. So so I think that really Derbyshire, also, well, somebody somewhere needs to get their act together, and Derbyshire need to get. I have a lot of trouble with Derbyshire, in general. Not talking to other trusts and not talking to other CCGs, and it's very, very frustrating, because as a patient I end up doing all the facilitating, which is difficult when you're not well. But it seems to be that if I don't do that, it doesn't get done, and there doesn't seem to be any method for me or for patients. And I'm quite a proactive patient, so I do that. But if you're not, you'll get slipped through the cracks. And I think I'm struggling with, because when I go into these calls, a lot of them are about Derbyshire, but the High Peak is never mentioned. It's all Derbyshire Dales and that side of the Pennines, and we're not mentioned.
So Stella, hi, sorry to hear that you're having such problems. It's interesting that you think you have a problem with Derbyshire. I suspect that this is actually a national issue, that when you're a patient under more than one trust, we do know that there shouldn't be, but there are inevitably some communication issues. I think it's difficult on a call like this to talk about specifics, and I'd be interested to hear if Monica has anything to add, but I suspect this is something that if you feel you've got an issue, you probably do need to discuss and have it looked at. This will be a national problem about communication between teams at different trusts, I suspect, and not a Derbyshire specific problem. You just happen to be in Derbyshire and therefore you see it as a Derbyshire problem. And also where you live does come under Derbyshire. Let's just reassure you of that this is, you do live in an area that is part of Derbyshire. Monica, I don't know, do you have anything to add?
Hi Stella, and thanks for sharing. I think it'd be really interesting for you to use our inquiries service, Stella, so that we can find out a little bit more and try to help you unpick it. I think it is complicated because as commissioners, we commission for our Derby population. But when we've got patients who live on the borders, it's not just the High Peak. We've got people in Ilkeston who go to Nottingham, Chesterfield, Sheffield, Derby, Burton. So we've got a lot of we have a lot of boundaries that we try to navigate, and we do have quite good links with a lot of our neighbouring providers. So it's difficult to be able to answer the question specific that you've raised today. But please use the inquiries line so that we can try to get to the bottom of it. But it is a national issue. Now we work towards various alliances. Stella, you're on mute. Sorry.
Where's the inquiry line?
Lee, are you able to share that? There you go.
I can see
I'll just put, thank you. It's just things like that. People will say that, but then unless and the other thing that I want to pick up on is there are a lot of elderly patients, I mean older than me, in their 70s and 80s, who don't have access to computers. And they might have a smartphone, but they don't see that as having access to the internet. I know this sounds bizarre, but they see it. They've got access to Facebook, but they don't see that as having access to the internet. And
no, so I understand that.
There's also that question of, and it's not specifically cancer related. It's a general question. It's a general thing in the whole of the NHS, is that you get this population of older people, or even of my age, who aren't technical, if you like, who aren't internet friendly, and so I think, and I do recall being on focus groups at the beginning of COVID. and saying that, you know, it isn't a one size fits all. I love it. For me, it works. It's brilliant. I love it. I love the video calls. I love the phone calls. I'd rather do that. There are times where you have to go into the hospital, but, you know, for me, it works, but I know it doesn't work for everybody. But thank you very much. I will email.
Stella, I think that's actually a really useful point to consider there. Maybe Lee, it's something for a future Derbyshire Dialogue, because I know the digital team across Joined Up Care Derbyshire have done quite a bit of work around digital exclusion, and you know, they're building that into their future strategy. So maybe it'd be really good to get them to, you know, as a future session, without nominating my colleagues for this, but I think it'd be really useful for them to share, you know, their thoughts on it and what we're doing to try to mitigate some of that risk.
Yeah, and I absolutely agree with you. There is over the course of the pandemic, obviously there's been a lot of transformation in the way that we communicate, and a lot of that has been good, but we've identified that there's clearly a group of people, and you can even take age out of the equation, because not everybody has access, you know, to devices to get in touch digitally. It's actually works the other way around in many instances for older people, that they don't have the barriers to transport and things to get to where they needed to go before. But the other side of the coin with that is the digital exclusion, and that is a specific workstream area that's been focused on. And we can pick up on some of the things that have come out of that and are being done to mitigate that risk, as you say. One example off the top of my head, I know we've from the pandemic, we came out with a digital exclusion checklist that we've circulated around provider and commissioner organisations, so that when they're making a service change, they can check that the changes that are being made to these services, and we've seen a massive amount of change to services, obviously through the pandemic, that those factors are being taken into consideration. So very valid point, something we are actively considering, and something I think we can pick up on at a future session.
And certainly when we work in our practice, I mean, I recently went along and talked to our local parish council. I mean, our plea to our community is, you know, if you know of people who are struggling to access their GP because of these issues, then please bring them to our attention. You know, we do want to be able to allow these people to access us. So I think if you are having difficulties, then you do need to get that message to your practices.
Yeah, fantastic. Thank you very much. And I would like to echo that sentiment. I'm just kind of jumping between the chat box now and the hands that we've got up. And I can see that Lynn has come in to say, I'd like to add that people with learning disabilities may also struggle with accessing video calls and technology. Yeah, 100%. That's something that's been picked up and I've seen in some of the reports that have been gathered on patient experience. So I think that links in with the wider point and is one of the areas. I'm going to go to Peter now and bring Peter in, if that's okay.
Yeah, thanks, guys. It's nice to see everybody. There's only two really quick points. One, I think Stella's brought it up about technology for the older generation. That's something I've been certainly concerned with for many years. A lot of people can't understand the tech. They mind trying to get like we are onto Teams and things like this. And not only that, it's an expensive commodity for a lot of people nowadays, especially with the bills, etc., going up as they are and rocketing. The first point I was going to bring up is that you were talking about trying to get an appointment with a doctor. Well, our doctors, you can phone up for 1 minute and you can be on the line for above an hour in some cases. You are number 59. Well, to try and access a doctor when you're not feeling well, that's an impossibility, especially to what I've just picked up some information. Our particular doctors are actually joining forces with another practice. And if that's the case, are we going to be waiting for 2 hours to go to speak to somebody on reception? And then when you actually do get an appointment, it's not necessarily the type of person you want to talk to. You've got to give that information over to your receptionist to put you in the right direction. Why? When they're not officially doctors. Oh, that makes a bit of sense to you.
So practices do have other people other than GPs, and receptionists ask for details to try and refer the person to the most appropriate clinician. So they are clinicians, they may not be GPs. Okay.
Thank you.
So increasingly, you may experience seeing a nurse practitioner, an ANP, a physician's assistant, but you would hope that that would be the most appropriate person for them to see. And also those people, those clinicians know if they see something and they feel they need the experience of a general practitioner, that they can go to them and ask for their opinion. So these are unfortunately...
Yeah, sorry for interrupting you. I don't disagree with that at all. My point is, I think a lot of the time is when you have to explain to the receptionist why you want to see them, when they are not trained clinicians or doctors.
No, they're not trained clinicians or doctors, but as I just tried to explain, they do have protocols that they work to. I mean, you know, it's interesting, isn't it, that the politicians hold up 111 as, you know, a very accessible healthcare advice system. None of those are clinicians. They all work to protocols. So our receptionists are trained to a level that they know what sort of symptoms need to be directed to what type of clinician. So that's why they ask for further information, so that that person can be dealt with more appropriately.
It's just complaints I've had all the way through from different people in our particular area, saying why they're not clinicians, they're not this, why are they interfering with us? But go on. Totally agree. Thank you.
Thank you. And I've just dropped into the chat there to add on to Louise's point that we're currently running a campaign to showcase the fact that there are a variety of health and care professionals that you can essentially be triaged to via a receptionist when contacting your GP. So I popped that in the chat and you can see some information on that there. I do appreciate, because as we've been highlighting, that is being rolled out across the county, there's disparity amongst GPs, and there may not be all of those roles in different practices. So it's not necessarily consistent across the practice, but it is something that's happening. And I think links in with that point there that, yeah, you might not go straight through to a GP, but it's essentially trying to streamline the process and get people to the right place as soon as possible. Okay, fantastic.
Just to add to that, Lee, can I just say, just to add to that, there is a move within Derbyshire to see our non-clinical staff, so our patient-facing receptionists, for example, trained even more in terms of picking up sinister symptoms, so that patients are very appropriately dealt with. So, you know, we do understand how difficult it is for people to talk to a receptionist. They do sometimes find it quite intrusive, but I think along with training our receptionists, we have to get the message out to the public why that is important.
Thanks, guys.
Yeah, absolutely. And any help getting that message out, just like with the other things, is always appreciated. And these forums can be really effective in doing that. So yeah, please do get in touch if you can help, or share those messages. I'm going to go to Peter again, but Peter Steedman, I'll bring you in now. We had two Peters with hands up before, so apologies for any confusion. Good to see you, Peter.
Hi, Lee. Thanks for bringing me in. Morning, Louise and Monica. My two very quick questions, I think, pale into insignificance after having heard Stella's story. So I just like to make that point. Yeah, my first quick question is, you mentioned about no shows, Louise, and is there anything you feel that we may want to do differently in future to try and reduce no shows? When I go into my GP surgery, I see information there about the amount of money it's costing the NHS and the number of GP appointments that are being missed. I very much a blame type of message. And maybe we need to think about the communications possibly slightly differently in that respect. My other quick question was, with regards to the application of non-specific pathways, I mean, by definition, that is indistinct, and hence it's going to be difficult to actually define when that pathway should be applied. So is there a danger of that pathway being overwhelmed, and how we're going to avoid that? Thanks.
Hi, Peter. Two really, really important questions. I think you're right. For years, we've done the numbers in the waiting room, the blame game about, wasting money, not attending, etc. And I think that as a professional, I can see that we have to communicate better with patients. So particularly when it comes to patients being referred for sinister symptoms that could be down to a cancer diagnosis, it's really important that the clinician dealing with that patient and referring that patient has a very open and transparent conversation with that person for them to understand how important that next diagnostic test or that referral is. And I think that we know from research that's been done, historically, professionals have found it very difficult to perhaps have those open and transparent conversations. Equally, I think patients come and they're anxious and they're uptight, and sometimes those conversations do take place and the patient doesn't perhaps take them on board. So I think that first and foremost, we have to encourage my professional colleagues to have those conversations. Often, actually, patients feel quite relieved when the big C word is mentioned. Let's talk about cancer more openly, more frequently, so that people aren't so shocked when we talk about it. I mean, let's face it, anyone born after 1962, 1 in 2 people will get at least one cancer in their lifetime. We should start considering it like a chronic disease, like diabetes and chronic heart disease. And one of the main reasons for that is that for most people getting cancer now, or a lot of people getting cancer now, they will do very well with treatment. So we need to be having those conversations so they understand the importance of attending. We need to check that that person does intend to go, because sometimes people don't understand that they have to be available within the next couple of weeks. And so they make an assumption that someone will work round a holiday or an important family event. And sometimes it is right for that person to prioritise that important family event above and beyond the next diagnostic test. And then we have to back that up with written information, because, as I say, most people, I would say, when you walk out of a conversation of any type, only remember a part of it. So it's about having those conversations in the first place and backing it up with good written material, which again is in the right language. If it's somebody with some learning disability, that it's appropriate for them. And then moving on to the non-site specific pathways, oh my goodness, yes. So many people present in general practice with vague symptoms. But it is a wood from the trees thing. And what we've done in Derbyshire is we've tried to make it as sustainable as possible. So first of all, it's about the clinician taking a good history and ensuring that they understand the length of those symptoms. So I'm not going to take for granted if someone says to me, oh, yes, I've lost some weight, doctor. I'm going to try and evidence that. So how much weight over what time period? Right, let's put you on my scales. I'm going to look at that patient. That's not the patient I'm going to be assessing over the phone. That's the patient I'm going to want to see face to face. But then the great thing is that then as a GP, I can access a panel of blood tests and some scanning if I want it prior to any referral. And after lots of conversations with people far more knowledgeable than myself, we've come up with a panel of tests which, if they are all negative, then in most cases we can reassure those people. But the other lovely thing is that we now have this clause that if the GP is just still concerned, all the tests are negative, even the CT scan may be negative, but they have ongoing concern, then it's saying to the clinician, look, even if you don't want to refer, perhaps use advice and guidance, talk to your secondary care colleagues to just make sure that we are able to reassure this patient that they don't have a problem. And then moving on from that, and this isn't just about non-site specific, it's about the site specific as well. All of us as clinicians need to make sure we safety net those people properly, because what happens is everybody loses track of time, and COVID's been dreadful for losing track of time. So people will come, they'll be reassured about a symptom, it may then return, and they're thinking, well, I saw Dr. Merriman about that. Was it a couple of months ago? And she said I was okay, so I won't bother them again. So it's about giving people that permission again to re-access the service. So, you know, I need to be saying to someone, look, all these tests are negative at the moment. Your weight seems to have stabilized, but if you in a couple of months' time find that your weight is going down again and you can't explain it, or you develop any other symptoms, and I might give them some written information on the sort of symptoms I'd be worried about, then please give me another phone and we can start some further investigations if I think they're indicated. So, you know, I hope that kind of explains that, yeah, it is tiger country out there. And, you know, at the end of the day, clinicians are only human. We won't get it right all the time, but I think it just widens our net a bit more to enable us to pick up, hopefully, these rather non-specific symptoms that are actually going to turn out to be a cancer at an earlier stage.
Yeah, it's a very quick comment. I suppose that the best practice approach, to say it, that you've just described, I suppose another challenge is to make sure that that best practice is spread across all your GP colleagues, isn't it?
Oh my goodness, Peter, if you've got any ideas on that, come and help me, because, you know, we all work differently. We all have different ideas. We all have different pressures. We all have different types of populations that present to us. You know, it is very, very difficult. And that's why, unfortunately, we won't get everyone all the time. But, you know, along with the commissioners, as a clinical lead, what I want to do is try and get equality across our entire patch, whether you live in High Peaks or Southern Derbyshire or North Derbyshire. I want to see patients feeling confident that they can present to their GP with a particular symptom and be treated in the same way. But it's a big challenge.
That's great. Thanks.
Okay, thank you very much. Now, I'm mindful of the time, so I'm just very quickly, I'm going to jump to the chat box and just make a couple of comments, and then I'm going to bring Leslie in for the final question, if that's okay. So, Juliet, I know that your comment about disparity on who's been offered a video appointment in the different primary care networks, and I think that's something, if that's okay with you, we can pick up and come back to you for a response on that one. And Brian, I take your point on the fact that basically, if you can't get through to a GP in the first place, when we're talking about the accessing different healthcare roles, or, you know, when we're talking about cancer, then it's a moot point. We are doing some work at the moment for those that are experiencing long wait times. We've noticed it locally. It's happening nationally, about people being able to get through to their GP practice. So I've seen it in the BBC today, in fact. So we're running a survey locally to see the data that we can collect, and I'm going to just pop that into the chat now. So if anyone is having experiences with particular GP practices, then we're looking to be active on that, and see what data we can collect and see if there are any improvements that can be made. There's also some information in there when we're talking about the point of accessing GPs, that there are alternative, and I'm coming away a little bit, I appreciate, from the cancer services element here, but for other ailments and as such, that I've just put some information there about alternative methods for accessing care, depending on what care it is you're looking to access. So I hope that's okay. And I'm going to bring Leslie in for the final question, just mindful of the time.
Thanks very much, and thank you for a really informative session and for joining us with a conversation here. It's been really good. It's in line with the last couple of comments that have been made really by other participants. They're trying to get GPs to be more confident in engaging in shared care and shared conversations with their patients and dealing with difficult situations. We do have a course now on motivational interviewing, which many have done, and I've done it. It's a fantastic course, absolutely brilliant, and can be incredibly helpful if it's supported with sort of preceptorship afterwards. I suppose my question really would be, is there any move to try and ensure that all GPs are encouraged, if not required, to undertake this course? It's not a long course.
Well, I don't know the specifics about whether that course is being used, Leslie, but GPs are constantly encouraged to increase their communication skills. We, in terms of trying to challenge GPs to do better and also to help them, we have got the Cancer Pathfinder, which is a referral decision support tool that all GPs have access to now on their systems, which reminds GPs to have those conversations. The referral letters also remind GPs to have those conversations. And also they have access at the press of a button to good written information to give to their patients. So, you know, there's always sort of leadership courses, motivational courses that are accessible to GPs and to all clinicians, but it's about time often, I would say, you know, and sometimes there is a cost to them as well. I don't know whether Monica has any thoughts on the Quality Conversations programme.
Quality Conversations, it's been rolled out. I know that it's been really, the uptake's been really strong across Derbyshire. We've been really pleased at how many people have participated. I don't know about GP uptake, but I've written in the chat earlier on, we do have cancer leads at each of our PCN, so maybe it's something we can look to promote further again, you know, to share that message. But I mean, we're also quite keen that it's not just GPs that access it, that it's all staff. We want the receptionists to be thinking about this way of communicating with people as well.
Okay, brilliant, fantastic. Thank you very much. Thank you, Louise and Monica, once again for coming and some really positive comments in the chat box. I think it's a really good conversation to be had. As you know, it's obviously a very sensitive and topic, but it's good to have the conversation and try and get this dialogue going. I'm mindful that we're past 12 o'clock, and thank you, Nicola, because I can imagine it's quite exhausting with the BSL interpreting when you've joined at 1:45. So I'm going to bring the session to a close. I've picked up a couple of comments from the chat box that we'll get back to. Yes, we'll circulate the slides around to everybody that's attended. I think they did go out ahead of the session to those that registered, but we'll recirculate those as we do. And there's always the Derbyshire Dialogue engagement platform section that you can go to and ask any questions that I'll put the link in the chat to. So thanks very much, and thanks for coming along, and hopefully we'll see you at the next session. Thank you.
Thank you.
Thank you.
Lee. Thank you, everybody.
Thank you.
Thank you.
Bye bye.